Disclaimer: case studies are illustrative. Strategies and systems are based on real-world ASC billing practices. 93% of physicians say prior authorization delays necessary patient care. Nearly 1/3 of all prior authorization requests get denied. But here's the part that should terrify every ASC administrator. When those denials are appealed, over 80% get overturned. That means most prior authorization denials aren't legitimate, they're process failures, and they're costing your surgical center hundreds of thousands of dollars every single year. I'm Francisca, and on January 19, 2026, CMS launches a mandatory prior authorization demonstration for specific ASC procedures in 7 states. If your center doesn't have defense systems in place right now, you're about to see your denial rate spike. By the end of this video, you'll understand the 5 most expensive prior authorization mistakes, why having a valid authorization doesn't guarantee payment, and exactly how to build the 5-stage defense system that prevents 90% of prior authorization denials before they happen. This isn't theoretical, this is survival. Let me tell you what happened at a multi-specialty ASC I audited. 2,000 procedures per year, experienced schedulers, and a dedicated authorization coordinator. Still, their cash flow was tightening and denials were climbing. I pulled their data and found an 11.8% initial denial rate, right at the industry average but up significantly over the last few years. The number one cause? Prior authorization process failures. Invalid numbers, mismatched procedures, wrong facility, expired authorizations. And here's what made this expensive. The average ASC procedure runs $8,000 to $25,000. At an 11% denial rate with 2,000 procedures annually, you're looking at 220 denied claims. Even if you recover half through appeals, that's 110 claims times an average of $15,000. That's $1.6 million in delayed revenue and over $800,000 in potential write-offs. The authorizations existed, they just weren't being managed correctly. Small process breakdowns were creating massive revenue leaks. So what is prior authorization? It's a payer's review of a procedure for medical necessity, provider status, and plan coverage before it happens. If approved, they issue an authorization number, which is a conditional approval, not a promise to pay. And 2026 is the inflection point. CMS is launching a mandatory prior authorization demonstration in 10 states, starting January 19th in 7 states: California, Florida, Georgia, Maryland, New York, Pennsylvania, and Tennessee. 3 more states, Arizona, Ohio, and Texas, follow on February 16th. It covers specific procedures like blepharoplasty, Botox injections, and vein ablation. If you're in one of these states and bypass the process, your claims face automatic prepayment review. Getting the authorization number isn't the finish line, it's the starting line. You still have to record the number correctly, match CPT codes exactly, verify the right provider and facility, track expiration dates, and submit claims before authorization validity expires. Every single one of those steps is a potential failure point. According to the AMA, physicians and their staff already spend 13 hours per week on prior authorizations, completing an average of 39 prior authorizations per physician per week. 89% say it contributes to burnout. With this new mandate, the volume of mistakes is about to multiply. Mistake number 1: recording authorization numbers incorrectly. This sounds simple, but a single transposed digit or missing hyphen in an alphanumeric authorization string can get your $22,000 claim instantly denied. Your scheduler calls the insurance company, waits on hold 15 to 30 minutes, and finally reaches a representative who rattles off the authorization number. Alpha-73259-Delta-4. Your scheduler hears it, writes it down as A73259D4. One error, one transposed digit or missing hyphen, and you submit the claim with that number. Insurance rejects it immediately. Invalid authorization number, not on file. Your $22,000 shoulder arthroscopy gets denied. Now you have to research the correct number, locate the authorization documentation, correct the claim, resubmit it. Except now your day 60 post-procedure and the timely filing clock is ticking. For a high-volume pain management center running 300 to 400 procedures per month, if even 10% of authorization numbers have transcription errors, that's 30 to 40 claims per month getting denied for invalid authorization. That's nearly $1 million a year. The fix is simple: double entry verification. Read the number back to the rep on the call, enter it into the system. Have a second staff member verify it matches the verbal confirmation before scheduling the surgery. This one change can drop these errors from 10 to 15% down to under 3%. Mistake number 2, CPT code mismatch. A surgeon recommends a knee replacement, CPT 27447, and gets it authorized. But during surgery, they discover more extensive damage and perform additional medically necessary procedures. Your coder correctly codes for all the work done. The insurance company pays for the authorized CPT code but denies the rest, procedure not authorized. You just lost $5,000 to $15,000 in legitimate reimbursement for medically necessary work that couldn't have been predicted from imaging, and you can't call mid-surgery for authorization. The solution is twofold. Proactively request authorization for associated procedures based on intraoperative findings when requesting the initial authorization, and retrospectively request authorization within 24 hours for any additional work performed, with full documentation. Attach the complete operative report. Document why the additional work was medically necessary and why it couldn't have been anticipated. Mistake number 3, wrong provider or facility. The authorization is valid, but it's for the wrong doctor or the wrong location. This happens more than you think, especially with multiple facilities or rotating surgeons. A patient needs cataract surgery. Your scheduler calls insurance for authorization and provides patient information, procedure code, surgeon name. The insurance system pulls up the patient's record. The insurance representative issues authorization to the hospital, not your ASC. The authorization exists, it's valid, but it's not valid for the actual provider and facility combination that performed the surgery. The claim is denied. Provider not authorized, facility not authorized. Your ophthalmology center just lost $8,000 on a routine cataract surgery. The fix? Aggressive verification. When you get the authorization number, confirm the provider NPI and facility NPI on the call. This authorization is for Dr. Jones, NPI 1234567, performing the procedure at Valley Surgery Center, NPI 89012334, correct? Get verbal confirmation. Document the representative's name and confirmation in your system. If they say the authorization shows a different provider or facility, correct it immediately while still on the call. Don't wait for the denial. Mistake number 4. Authorization expires before claim submission. An authorization is valid for 90 days. The surgery is on day 60, but some payers require the claim to be submitted within that 90-day window, not just the surgery performed. If your billing department waits for the operative report, waits for pathology if applicable, waits for any other required documentation, and the claim gets submitted after the authorization expires, it's denied. Authorization expired. Some payers require the claim submitted while authorization is still valid. The defense is systematic tracking. Every authorization needs a claim submission deadline, and any surgery scheduled close to expiration needs expedited billing. Set the claim submission deadline as the authorization expiration date, not the surgery date. If surgery is scheduled within 30 days of authorization expiration, flag it for expedited billing. Submit the claim immediately after receiving operative documentation. Don't wait. Mistake number 5. Timely filing violations. This is the death spiral. A claim is denied, and the clock starts ticking on your timely filing deadline. The rework from the first 4 mistakes eats up time. Before you know it, you've missed the window to appeal or resubmit. The revenue is gone forever. This isn't a single mistake. It's the catastrophic result of a series of small, unmanaged process failures. A A systematic defense is the only way to prevent this. So how do you prevent these catastrophic failures? With a 5-stage prior authorization defense system. This is the framework that prevents 90% of authorization problems before they happen. Stage 1. Preoperative verification. Before you even request authorization, verify everything. Patient insurance eligibility, CPT codes, provider and facility NPIs, and whether authorization is even required for this specific procedure and payer combination. Don't assume, verify. Stage 2. Authorization request with clinical documentation. When you call for authorization, have all your clinical documentation ready: diagnosis codes, medical necessity rationale, imaging reports, previous treatments that have been attempted. The more you provide up front, the lower the denial risk. Stage 3. Real-time tracking. Every authorization goes into a tracking system with the number, issue date, expiration date, and all approved codes and providers. This data must be accessible to everyone involved: schedulers, billers, and coders in real time. Stage 4. Pre-submission verification. Before any claim is submitted, verify that the authorization details match the claim. Does the CPT code match? Does the provider match? Does the facility match? Is the authorization still valid? If anything is off, fix it before you hit send. Stage 5. 72-hour denial response. If a claim is denied for authorization reasons, you have 72 hours to assess, fix, and resubmit, or file a protective appeal. This protects your revenue while you resolve the issue and protects your timely filing rights. Here's how to implement this system. First, audit your authorization denials from the last 6 months to find your biggest leaks. Second, implement double entry verification for all authorization numbers. This drops invalid number denials by over 80%. Third, create a centralized tracking system. Update it in real time and review it daily. Fourth, use a pre-submission checklist to verify every claim against its authorization. Fifth, establish a 72-hour rapid response protocol for any authorization-related denials. Prior authorization is about to get much more complex. The CMS mandate is coming. ASCs with systematic authorization management have denial rates under 5%. Those without are seeing rates of 11 to 15%. On 2,000 procedures a year, that's a difference of millions of dollars in denied claims. The 5-stage defense system is your key to survival. Subscribe to Francisca Knows AR for more strategies on protecting your revenue. Get your systems ready now. Thanks for watching.